what is your exam like when you're seeing these patients in clinic? Like with adults, I'll frequently, I'm doing a scope exam so that I can really look at the eustachian tube opening. In kids, are you able to do that in clinic? Are most of them letting you put a scope in their nose, or is it variable?
Yeah, well, it's a little variable, but the eight and older, most of them are fine doing it. Just go with a pediatric scope. These are typically 2.7 millimeter diameter. I flop it in front of their eyes, say, you see, looks like a piece of spaghetti.
Mm-hmm.
And they're generally very good with that. So just going slow. Now, not everybody's up for it. If they get a tear in their eye, I'll quickly not do it and just defer that to the operating room if it comes to that.
Yeah. Do you decongest their nose? Like, do you do spray or anything to help with that, or does?
Yeah, I do. So we use a combination of the oxymetazoline and the topical lidocaine. So we do a quick spray in each nostril, and I tell them that's the worst of it.
Yeah.
Now that that's over, the rest will be easy.
And when you're looking at the eustachian tube, what does that look like? You kind of describe how your exam, what your thoughts are when you're kind of looking at that.
So once the scope's in the nasopharynx, I'll turn it sideways so I can go back and forth across the vomer. And I'll look at each eustachian tube, have them say ka, 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 just to move the torus with the action of the levator muscle. And because of the eustachian tube opens with the action of the two muscles, the levator medially rotates the torus, sets a stage for the tensor muscle to open the valve. So you got to have both of them working. So the ka, ka, ka moves the levator, and then swallows. That's a normal physiological opening. And then saying ah or a big yawn, that's a maximal sustained dilatory effort. And what I'm looking for is how well does that valve open or not? What's the severity of the pathology in the lumen of the eustachian tube? Is contact with the torus interfering with opening of the valve? Typically, if it traps the torus when they swallow, you get what I call anterior thrusting. The torus gets pushed forward anteriorly and blocks the valve when they're swallowing. Very, very common with adenoid hypertrophy, and particularly in kids. So looking at those points, and then I'm looking at the valve for a patchless defect, because it's so common in the kids, especially if they've got allergic disease. And you can see robust inflammation in the whole nasopharynx, the orifice of the eustachian tube, and even this cobblestoning going down into the lumen, adenoid-like tissue in the lumen, and yet in the membranous wall, not the cartilaginous torus wall, but the opposite, anterolateral membranous wall, you can actually see a defect in the valve sometimes where it's beginning to get atrophic. Chronic allergic disease is associated with patches of atrophy in the nose, sinuses, and you can get it in the valve of the eustachian tube. That's why so many of these patients become patchless. So I'm looking for those things. Inflammation in the lumen, the severity, how well does it open or not, patchless defect, and the adenoid.